Block simulation 35. Same process, press set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which statement about lung compliance is correct? A physiologist studies lung compliance, how easily the lungs expand, and why the inflation and deflation curves differ. Read the command. Which lung compliance statement is correct? Compliance is change in V or change in P. Emphysema increased compliance, loss of recoil, fibrosis decreased. Hysteresis is inflation is not equal to deflation, surfactant. Lung compliance is the change in lung, volume per change in distending pressure, change in V or change in P, essentially how easily the lung stretches. High compliance is easy to inflate, low compliance is stiff. Compliance is determined by the lung's elastic tissue and by surface tension. In emphysema, destruction of elastic fibers means loss of elastic recoil, so the lungs become floppy and easier to inflate. Compliance I increases, but they don't empty well. In pulmonary fibrosis, the stiff, scarred lungs are hard to inflate. Compliance decreases. The correct answer is E, tastes. Refers to the observation that the pressure volume curve during I inflation is different from the curve during deflation. The lung follows different paths. It takes more pressure to inflate the lung, especially to open collapse alveoli against surface tension, than to keep it inflated during deflation. This is largely due to surface tension at the air-liquid interface and the action of surfactant, which reduces surface tension and stabilizes alveoli, improving compliance. Compliance is greatest in the mid-range of lung volumes, functional residual capacity. The change in V or change in P definition, with emphysema raising and fibrosis lowering compliance and hysteresis from surface tension is correct. What is the diagnosis and the mechanism? A 45-year-old non-smoker has recurrent episodes of chest pain occurring at rest, often at night, with transient ST segment elevation that resolves. Coronary angiography shows no fixed stenosis. Symptoms are relieved by calcium channel blockers, and a provocation test induces coronary spasm. Read the command, diagnosis, and mechanism. Rest chest pain, transient ST elevation, no fixed stenosis, CCB responsive, spasm, Prinzmetal, vasospastic, angina. This is Prinzmetal, variant or vasospastic angina. The mechanism is transient. Coronary artery, vasospasm. The smooth muscle of an epicardial coronary artery constricts, causing reversible transmural ischemia. Without a fixed atherosclerotic stenosis, angiography may be normal. Because the ischemia is transmural, the ECG shows transient ST segment elevation during the episode, which resolves as the spasm relaxes. The correct answer is B. The clinical pattern is the giveaway, chest pain occurring at rest, not with exertion, often in the early morning or night, in younger patients who may not have classic coronary risk factors, though smoking is a risk. It can be provoked by ergonovine or acetylcholine testing and is associated with other vasospastic disorders, Raynaud, migraine, and with cocaine use. Treatment is calcium channel blockers, the mainstay, and nitrates, vasodilators. Patients should avoid triggers, cocaine, triptans, and non-selective beta blockers, which can leave alpha-mediated vasoconstriction unopposed. The rest pain, ST elevation, spasm-driven angina without fixed stenosis is Prinzmetal angina. Which statement about fatty acid oxidation is correct? A biochemistry student studies how fatty acids are broken down for energy, beta oxidation, and where it occurs. Read the command. Which fatty acid oxidation statement is correct? Mitochondrial, carnitine shuttle, CPT 1/2. Each cycle leads to acetyl-CoA+, NADH+, FADH2, major fasting fuel. MCAD-D defect leads to hypoketotic hypoglycemia. Fatty acid beta oxidation occurs in the mitochondrial matrix and is the major energy source during fasting and prolonged exercise. First, fatty acids are activated in the cytoplasm to FATACL-CoA. Long-chain acyl CoA cannot cross the inner mitochondrial membrane directly. It must be ferried in by the carnitine shuttle, carnitine palmitoid transferase, ICPT1, on the outer membrane, the rate-limiting or regulated step, inhibited by malonyl CoA, then CPT2 on the inner side. The correct answer is D. Once inside, beta oxidation runs in repeating 4-step cycles, each removing TW carbons from the fatty acid and yielding 1 acetyl-CoA plus 1 NADH and 1 FADH2. The acetyl-CoA enters the TCA cycle, or, in the liver during fasting, forms ketone bodies, while the NADH and FADH2 drive oxidative phosphorylation, making fat a very energy-dense fuel. Defects are high yield, medium, chain acyl-CoA dehydrogenase, MCAD. Deficiency impairs this pathway, so during fasting the patient cannot make ketones or use fat leads to H-hypoketotic hypoglycemia and dicarboxylic aciduria. Carnitine deficiency causes weakness and similar findings. The mitochondrial carnitine shuttle beta oxidation producing acetyl, CoA, NADH, and fatty H2 is carnitine shuttle beta oxidation producing acetyl-CoA, NADH, and FADH2 is correct. Which statement about the trigeminal nerve, CN5, and its 3 divisions is correct? A neurologist tests facial sensation and the muscles of mastication. Read the command. Which trigeminal statement is correct? V1, ophthalmic, sensory, soft. V2, maxillary, sensory, rotundum. V3, mandibular, sensory plus motor mastication, ovale. The trigeminal nerve, CN5, is the main sensory nerve of the face and the motor nerve to the muscles of mastication. It has 3 divisions. V1, ophthalmic, is purely sensory, supplying the forehead, scalp, and the eye or cornea, and exits through the superior orbital fissure. V2, maxillary, is purely sensory, supplying the midface, maxillary teeth, and palate, exiting through the foramen rotundum. The correct answer is A. V3, mandibular, is the key division. It is both sensory, lower face, mandibular teeth, anterior tongue sensation, and motor. It innervates the muscles of mastication, masseter, temporalis, medial or lateral pterygoids, plus a few others, tensor tympani, tensor veli palatini, mylohyoid. B3 exits through the foramen, oval, standing room only, superior orbital fissure or rotundum, and oval for V1 and V2 or V3. CN5 also carries the efferent limb of the corneal, blink, reflex, V1, and the jaw jerk reflex. A trigeminal motor lesion deviates the jaw, toward the lesion. The V1 and V2 sensory and V3 sensory plus motor mastication framework is correct. What is the diagnosis and the mechanism? A 12-year-old boy has persistent microscopic hematuria, progressing to renal insufficiency, along with SE sensorineural hearing loss and ocular abnormalities, lens or retinal. There is an X-linked family history of similar problems. The defect is in type 4 collagen. Read the command, diagnosis, and mechanism. Boy, hematuria, plus sensorineural hearing loss, plus eye findings, X-linked. Type 4 collagen, Alport syndrome. This is Alport syndrome, a hereditary nephritis caused by a mutation in TYPE5 collagen, the major structural collagen of basement membranes. Most cases are X-linked, so it predominantly affects males with the gene COL4A5. The defective type 4 collagen produces abnormal, irregularly thinned and thickened basket weave on electron microscopy glomerular basement membranes, leading to persistent hematuria and progressive glomerular disease or renal failure. The correct answer is C. The key to recognizing Alport is that type 4 collagen is ALSO in the basement membranes of the COCH-LEAE and the EYE, so the syndrome is a triad of kidney EEA involvement, captured by CANT-SE, CANT-PE, CANT-HERA-B. Progressive nephritis, hematuria leads to renal failure, sensorineural hearing loss, and ocular abnormalities, anterior lenticonus retinopathy. It is distinguished from thin basement membrane disease, benign familial hematuria, and from IgA nephropathy. The type IV collagen defect affecting kidney, ear, and eye basement membranes is Alport syndrome. Which statement is correct? A renal physiologist studies how the kidney concentrates urine. This question targets the countercurrent mechanism, the medullary gradient, and ADH. Read the command. Which urine concentration statement is correct? Countercurrent multiplier. Thick ascending limb, NaCl plus urea recycling, builds medullary gradient. ADH leads to collecting duct aquaporins, leads to water reabsorption, leads to concentrated urine. This revisits urine concentration from the countercurrent or ADH angle. The kidney concentrates urine by creating a HY perisosmotic. Medullary interstitial gradient, from about 300 mosm in the cortex up to about 1200 mosm at the inner medulla, and then using it to reabsorb water. The gradient is built by the countercurrent multiplier of the loop of Henle. The thick ascending limb actively pumps out NaCl without water, the diluting segment making the interstitium salty. The descending limb is permeable to water, so the system multiplies the gradient down the medulla. The correct answer is B. Urea recycling is a key contributor often missed. ADH increases urea permeability of the inner medullary collecting duct, so urea diffuses into the interstitium and adds substantially to the medullary osmotic gradient. The countercurrent E-exchanger of the vasa recta preserves it. The crucial point about ADH, it acts on the collecting duct, not the loop, where it inserts aquaporin 2 water channels into the apical membrane via V2 receptors, allowing water to be reabsorbed down the medullary gradient, leads to concentrated urine. No ADH or nephrogenic DI leads to dilute urine. The countercurrent multiplier gradient, NaCl plus urea, used by ADH at the collecting duct is the answer. Which statement about central alpha-2 agonist is correct? A patient with resistant hypertension is started on clonidine. It is also used for opioid withdrawal and ADHD. Read the command. Which central alpha-2 agonist statement is correct? Clonidine or methyldopa is central alpha-2 agonist, leads to decreased sympathetic outflow, leads to decreased BP. Uses HTN or pregnancy or ADHD or withdrawal. Abrupt stop leads to rebound HTN. Clonidine and methyldopa are central alpha-2 agonists. They stimulate presynaptic alpha-2 receptors in the vasomotor center of the brainstem, and because alpha-2 receptors are inhibitory autoreceptors, this DEC resists central sympathetic outflow. The result is reduced peripheral vascular resistance and heart rate, lowering blood pressure. Methyldopa is a prodrug converted to alpha-methylnorepinephrine, a false transmitter acting as an alpha-2 agonist. The correct answer is A. The uses and cautions are high yield. Clonidine is used for resistant hypertension, ADHD, and to ease opioid and alcohol withdrawal. It dampens the hyperadrenergic symptoms. Methyldopa is notably a preferred antihypertensive in pregnancy, safe, though it can cause a positive Coombs or hemolytic anemia and hepatotoxicity. The classic trap. Abrupt discontinuation of clonidine causes rebound hypertension, a sympathetic surge, so it must be tapered. The central alpha-2 agonist mechanism reducing sympathetic outflow with rebound hypertension on abrupt withdrawal is the correct statement. Which pairing of lung cancer type and paraneoplastic syndrome is correct? A patient with lung cancer is evaluated for systemic syndromes caused by the tumor. This question targets the paraneoplastic syndromes of lung cancer. Read the command. Which lung cancer paraneoplastic pairing is correct? Small cell leads to SIAEH and Cushing ACTH Lambert Eaton. Squamous leads to BTHRP hypercalcemia. This revisits lung cancer from the paraneoplastic syndrome angle. Lung cancers are notorious for producing ectopic hormones and immune-mediated syndromes. Small cell oat cell carcinoma, a neuroendocrine central smoking-associated tumor, is the classic producer of SIAADH. Ectopic ADH leads to hyponatremia. Ectopic ACTH leads to Cushing syndrome and the Lambert. 18 myasthenic syndrome antibodies to presynaptic calcium channels leads to proximal weakness that improves with use. The correct answer is E. CQMS-CL carcinoma, also central, smoking related, with keratin pills, classically causes hypercalcemia via PTA therapy, parathyroid hormone related peptide. Squamous is PTA therapy and hypercalcemia, the S's. Adenocarcinoma, the most common type, peripheral, also in non-smokers, is associated with hypertrophic osteoarthropathy, clubbing, periostitis. The mnemonic small cell leads to SIADH and ACTH or Lambert, Eaton. Squamous leads to PTH or hypercalcemia. The small cell SIADH and ACTH and squamous. PTH and squamous. PTH and correct. Which organism is the classic cause and what is the danger? An unvaccinated 3-year-old develops rapid onset high fever, drooling, dysphagia, a muffled hot potato voice, and sits leaning forward, tripod position with stridor. Lateral neck x-ray shows a thumbprint. Sign, swollen epiglottis. Read the command, organism and danger. Unvaccinated child, epiglottitis, drooling or tripod or thumbprint, airway emergency. Haemophilus influenzae type B. This is acute epiglottitis classically caused by Haemophilus influenzae type B, HYB, a small gram-negative coccobacillus which requires factors V and X to grow on chocolate agar. HYB's polysaccharide capsule is its key virulence factor. Epiglottitis is a rapidly progressive infection of the epiglottis, high fever, severe sore throat, drooling, can't swallow secretions, dysphagia, a muffled hot potato voice, and the child sitting forward in the tripod position with stridor. The lateral neck x-ray shows the swollen epiglottis, the thumbprint sign. The correct answer is D. The danger is the high yield point. Epiglottitis is an airway emergency. The swollen epiglottis can completely obstruct the airway. Do not agitate the child or examine the throat with a tongue depressor, can precipitate total obstruction. Instead, keep the child calm and secure the airway in the oar with anesthesia or ENT ready, then give antibiotics, ceftriaxone. H. Influenza also causes meningitis, otitis media, and pneumonia. It has become rare because of the HEP conjugated vaccine, so think HEP epiglottitis, especially in new and vaccinated children. The thumbprint sign, tripod position airway emergency, is Haemophilus influenzae type B epiglottitis. Which statement is correct? A physiologist studies the cerebral spinal fluid, CSF, and the blood-brain barrier. Read the command. Which CSF and BBB statement is correct? CSF made by choroid plexus, absorbed by arachnoid granulations. BBB is tight junctions. Crossocyte foot processes restricts entry. Cerebrospinal fluid, CSF, is produced mainly by the choroid plexus in the ventricles. It flows from the lateral ventricles, leads to through the foramina of Monro, leads to third ventricle, leads to cerebral aqueduct, leads to fourth ventricle, leads to out into the subarachnoid space via the foramina of Luschka and McGinty, bathing the brain and spinal cord. It is then absorbed back into the venous blood through the arachnoid granulations, villi, projecting into the dural venous sinuses. Obstruction or impaired absorption causes H. hydrocephalus. The correct answer is E. The blood-brain barrier, BBB, is the second high-yield concept. It is formed by the tight JHD junctions between capillary endothelial cells, supported by the basement membrane, pericytes, and astrocyte food proxies. This barrier tightly restricts what enters the brain: small, lipid-soluble molecules, O2, CO2, anesthetics, and substances with specific transporters. Glucose via GLUT1, amino acids, cross, but most large or charged molecules, many drugs, and pathogens are excluded. A few circumventricular organs, area postrema, etc., lack a BBB to sense the blood. Inflammation, meningitis, can disrupt it, allowing antibiotic penetration. The choroid plexus, production, arachnoid granulation, absorption, and tight junction BBB is the answer. What is the diagnosis, the mechanism, and the phases? A patient develops acute kidney injury after prolonged hypotension or shock, or after IV contrast or aminoglycosides. Urinalysis shows muddy brown granular casts and renal tubular epithelial cells. The kidney injury is intrinsic. Read the command, diagnosis, mechanism, phases. AK after shock or contrast or aminoglycosides, muddy brown casts, acute tubular necrosis, ischemic or nephrotoxic, initiation or maintenance or recovery. This is acute tubular necrosis, ATN, the most common cause of intrinsic acute kidney injury. It is the injury and death of renal tubular epithelial cells from two main mechanisms: ischemia, prolonged hypertension, shock, sepsis. The tubular cells, especially the proximal tubule and thick ascending limb, are highly metabolically active and vulnerable, or nephrotoxins, aminoglycosides, IV contrast, cisplatin, amphotericin, myoglobin from rhabdomyolysis, hemoglobin, urate. The sloughed dead cells form the hallmark muddy, brown granular cast in the urine. The correct answer is B. The clinical PHAs are high yield. 1. Initiation, the inciting injury. 2. The oliguric or maintenance phase stays to weeks of decreased urine output, rising BUN or creatinine, and risk of hyperkalemia, metabolic acidosis, and fluid overload, the dangerous period. And 3. The recovery phase, when tubular cells regenerate, often with a polyuric diuresis, and risk of hypokalemia or electrolyte wasting before full recovery. Lab-wise, ATN intrinsic shows a high FeNA, greater than 2%, unlike prerenal azotemia, FeNA less than 1%. It is usually reversible with supportive care. The ischemic or nephrotoxic tubular injury with muddy brown casts and the 3 phases is acute tubular necrosis. Which structures are found in the popliteal fossa, and what are its borders? A surgeon explores the diamond-shaped space behind the knee. Read the command. Which structures in popliteal fossa and borders? Popliteal artery or vein, tibial nerve, common peroneal nerve, borders biceps, femoris, semimembranosus or semitendinosus, gastrocnemius. The popliteal fossa is the diamond-shaped space behind the knee. Its borders are superolaterally the biceps femoris tendon, superomedially the semimembranosus and semitendinosus, and inferiorly the 2 heads of the gastrocnemius and plantaris. Its contents from superficial to deep include the tibial nerve and the common peroneal, fibular nerve, the 2 terminal branches of the sciatic nerve, which typically divides at the top of the fossa, plus the popliteal vein and the popliteal artery. The correct answer is A. The depth ordering and clinical relevance are high yield. The popliteal artery is the deepest structure, closest to the bone or joint capsule, with the popliteal vein superficial to it and the tibial nerve most superficial. Because the artery is tethered and deep in the fossa, it is at significant risk of injury in posterior canini, dislocation, or supracondylar femur fractures, making distal pulse or perfusion assessment essential. A popliteal Baker cyst can also occupy the fossa. The popliteal artery or vein, with the tibial and common peroneal nerves, bordered by the hamstrings and gastrocnemius, are the contents. How are these somatic or related disorders classified? A psychiatrist sees several patients. One is preoccupied and distressed by multiple physical symptoms for over 6 months. One is convinced they have a serious disease despite minimal symptoms and normal workups. One develops sudden blindness with no neurologic cause after a stressor. One intentionally fakes illness for attention. Read the command, how somatic or related disorders are classified. Somatic symptom disorder, illness, anxiety, conversion, factitious, sick role, versus malingering, external gain. These are the somatic symptom and related disorders, distinguished by whether symptoms are consciously produced and the underlying motivation. Somatic symptom disorder, 1 or more real, distressing physical symptoms accompanied by excessive thoughts, anxiety, and behaviors about them, persisting, typically at least 6 months. The symptoms are not intentionally produced. ILLNS is Anxiety disorder, formerly hypochondriasis, preoccupation with the fear of having or acquiring a serious disease, with minimal or no actual somatic symptoms despite reassurance and normal evaluations. The correct answer is D. Conversion disorder, functional neurological symptom disorder, neurologic symptoms, weakness, blindness, non-epileptic seizures, mutism, that are incompatible with recognized disease, often arising after a psychological stacel, and patients may show labile indifference, not consciously produced. The two are intentional or feigned conditions differ by motive. Factitious disorder, e.g. Munchausen, the person intentionally falsifies illness to assume the sick role, internal or psychological gain, no external reward. Malingering, intentional feigning for external gain, money, drugs, avoiding work or jail, and is not a psychiatric diagnosis. The somatic symptom or illness, anxiety or conversion, unconscious versus factitious or malingering, conscious classification is the answer. What is the diagnosis and the defect? An infant has progressive weakness, hypotonia, developmental regression, and central demyelination on MRI. Nerve studies show demyelination. Urine shows metachromatic material. The deficient enzyme is aryl sulfatase A, leading to sulfatide accumulation. Read the command. Diagnosis and defect. Demyelination plus metachromatic material plus aryl sulfatase, a deficiency or sulfatide accumulation, metachromatic leukodystrophy. This is metachromatic leukodystrophy, an autosomal recessive lysosomal storage disease, a sphingolipidosis. The deficient enzyme is aryl sulfatase A, whose job is to break down sulfatids, cerebroside sulfate. Without it, sulfatides ACC accumulate in lysosomes, particularly damaging the myelin-producing cells, oligodendrocytes centrally, and Schwann cells peripherally. The correct answer is C. The hallmark is demyelination of both the central and peripheral nervous systems. A leukodystrophy is white matter disease. This produces progressive neurologic deterioration. In the infantile or juvenile forms, loss of milestones, ataxia, weakness or hypotonia, peripheral neuropathy, and eventually dementia and death. Adult forms can present with psychiatric or cognitive decline. The name comes from the metachromatic staining of the accumulated sulfatides. Contrast, K-Rabi disease, galactocerebrosidase deficiency, globoid cells, and other leukodystrophies. The aryl sulfatase A deficient, sulfatide accumulating demyelinating disorder is metachromatic leukodystrophy. What is the diagnosis and the mechanism? A 30-year-old with cystic fibrosis or prior severe pneumonia or obstruction has a chronic cough productive of copious purulent sputum, recurrent infections, and hemoptysis. CT shows permanently dilated, thick-walled bronchi, tram tract, and signet ring signs. Read the command, diagnosis, and mechanism. CF, copious purulent sputum, hemoptysis, dilated thick-walled bronchi, bronchiectasis. This is bronchiectasis, permanent, abnormal dilation of the bronchi. The mechanism is a self-perpetuating vicious cycle, chronic eye infection and inflammation, and or impaired mucociliary clearance destroy the elastic and muscular components of the bronchial walls, so the airways dilate and become unable to clear secretions, which pulls mucus, promotes more infection, and causes more damage. The dilated airways are seen on CT as thick-walled, dilated bronchi, tram tract lines, and the signet ring sign. The correct answer is D. The clinical picture is a chronic cough productive of copious, foul, purulent sputum, recurrent respiratory infections, and hemoptysis. The inflamed, dilated airways have fragile vessels with clubbing in chronic cases. The causes are high-yield cystic fibrosis, the classic cause in young patients, thick secretions, recurrent pseudomonas, prior severe or necrotizing infection cycle, is bronchiectasis cycle, is bronchiectasis, bronchial obstruction, tumor, foreign body, primary ciliary, dyskinesia, cartagena, allergic bronchopulmonary, aspergillosis, ABP, and immunodeficiency. The permanently dilated, secretion-pulling airways from the infection-inflammation cycle is bronchiectasis. Which statement about GI motility is correct? A physiologist studies gastrointestinal motility, how the gut moves and mixes contents. Read the command. Which GI motility statement is correct? Peristalsis propels, segmentation mixes. Interstitial cells of Cajal is pacemakers. MMC, motilin, between meals. Gastric emptying regulated, CCK slows. GI motility serves two functions handled by two patterns. Peristalsis is the coordinated propulsive wave, contraction behind and relaxation ahead of the bolus that moves contents along the tract. Segmentation is rhythmic, non-propulsive contractions that locally churn and mix the chyme with digestive secretions and bring it into contact with the absorptive mucosa, predominant in the small intestine for digestion or absorption. The underlying rhythm, the basal-electrical slow waves, is generated by the interstitial cells of Cajal, the pacemaker cells of the gut. The correct answer is A. 2 more high yield points. Between meals, fasting, the migrating motor complex, MMC, driven by the hormone amotilin, produces periodic sweeping contractions that clear residual food and bacteria from the stomach and small bowel housekeeper. Erythromycin is a motilin agonist. And gastric emptying is tightly regulated. It is slowed by fat, acid, and hypertonic contents in the duodenum via CCK and neurofeedback, so the small intestine isn't overwhelmed. Gastrin and stretch promote emptying. The peristalsis propels, segmentation mixes, Cajal pacemaker, motilin, MMC framework is correct. Which statement is correct? A 25-year-old with known Hodgkin lymphoma is staged. This question targets the B symptoms, spread, and prognosis. Read the command. Which Hodgkin staging statement is correct? Contiguous spread. B symptoms, fever or night sweats or weight loss is worse prognosis. Localized, bimodal age, curable. Nodular sclerosing most common. This revisits Hodgkin lymphoma from the staging or clinical angle. Hodgkin lymphoma is defined by Reed-Sternberg cells, large binucleate owl-eye cells, CD5+, CD30+, and a background of reactive cells. Clinically, it characteristically presents as painless lymphadenopathy that SPREAtes in a contiguous, orderly fashion from one nodal group to the adjacent one, node to node, unlike non-Hodgkin lymphoma, which spreads non-contiguously or widely. It often presents localized, favorable for radiation, and has a bimodal age distribution, young adults and older adults. The correct answer is C. The B symptoms are the high-yield staging modifier, fever, drenching night sweats, and unexplained weight loss, greater than 10% over 6 months. Their presence, denoted B versus A for absent, indicates a more advanced or aggressive disease and a worse prognosis. The classic cyclical Pell-Epstein fever and alcohol-induced node pain are associated. The most common histologic subtype is nodular sclerosing, young women, mediastinal mass. Lymphocyte-rich has the best prognosis, lymphocyte-depleted the worst. Overall, Hodgkin lymphoma is highly curable. The contiguous spread, B symptom staging, and generally good prognosis is correct. Which statement is correct? An elderly patient on digoxin and a diuretic develops nausea, confusion, blurred yellow-green vision, and an arrhythmia. This question targets digoxin toxicity and its precipitants. Read the command. Which digoxin toxicity statement is correct? Inhibits sodium-potassium ATPase. Narrow index. Hypokalemia predisposes. Toxicity is GI, or confusion, or yellow-green vision, or arrhythmia. Treat digibin plus correct potassium. This revisits digoxin from the toxicity angle. Digoxin inhibits the sodium-potassium ATPase, indirectly raising intracellular calcium via the Na and K exchanger, leads to increased contractility, positive intratrope, and it increases vagal tone, leads to SLODB conduction, used for rate control in atrial fibrillation and for heart failure. It has a narrow therapeutic index, so toxicity is common in high yield. The correct answer is E. The crucial precipitant is hypokalemia. Because digoxin and potassium compete for the same site on the sodium-potassium ATPase, LOW potassium leaves more binding sites open for digoxin, leads to enhanced effect and toxicity. This is why concurrent loop or thiazide diuretics, which cause hypokalemia and renal failure, digoxin is renally cleared, are common triggers. Toxicity features: GI symptoms, nausea, vomiting, anorexia, neurologic, confusion, weakness, classic visual changes, blurry, yellow to green halos or xanthopsia, and arrhythmias is correct. And arrhythmias including AV block and the fairly specific bidirectional or atrial tachycardia with block. Treatment: digl-oxine, specific antibody, fragments, digibind, correct electrolytes, potassium, magnesium, and manage arrhythmias. The hypokalemia predisposed, yellow vision toxicity reversed by digibind including AV block, and the fairly specific bidirectional or atrial tachycardia with vomiting. Which viruses cause this fecal-oral acute hepatitis, and the key risk for one of them? A traveler returns from a developing country with acute jaundice, fever, nausea, and right upper quadrant pain after eating contaminated shellfish or water. Transaminases are very high. Serology shows anti-HAV AGM. The illness is self-limited and does not become chronic. Read the command. Which viruses cause fecal-oral acute hepatitis plus key risk? Anti-HAV, EGM, fecal-oral, self-limited, no chronic, hepatitis A and E. Hep E dangerous in pregnancy. This is acute viral hepatitis caused by hepatitis A and the analogous hepatitis E. Both are transmitted by the fecal-oral route, contaminated food and water, and, for HAV, raw or undercooked shellfish, often in travelers or outbreaks. They cause an acute, self-limited hepatitis, fever, malaise, nausea, RUQ pain, jaundice, very elevated transaminases, and, importantly, do not progress to chronic infection or cirrhosis. The mnemonic, the vowels A and E hit the bowel and don't go chronic. The correct answer is B. The serology, acute hepatitis A, is confirmed by anti-HAV IgM, current or acute infection, with anti-HAV e.g. indicating post-infection or immunity or vaccination. There is an effective HAV vaccine. The high-yield distinguishing risk, hepatitis E, while usually self-limited, carries a notably HAGH mortality in pregnant women. Fulminant hepatic failure. Contrast the blood-borne or sexually transmitted hepatitis B, C, and D, which can become chronic and cause cirrhosis or hepatocellular carcinoma. The fecal-oral acute non-chronic hepatitis A and E with HAV's danger in pregnancy is the answer. What is the immunodeficiency? A 25-year-old has recurrent sinopulmonary infections and GI infections, giardia, beginning in adulthood, with low levels of multiple immunoglobulin classes, IgG, IgA, IgA, IgM, but normal or near normal B cell numbers. There is an increased risk of autoimmune disease and lymphoma. Read the command. Which immunodeficiency? Adult onset recurrent sinopulmonary or GI infections, low multiple I classes, normal B cell numbers, autoimmunity or lymphoma risk. CVID. This is common variable immunodeficiency, CVID, the most common symptomatic primary antibody deficiency in adults. The defect is in BCELL. Differentiation. B cells are present in normal or near normal numbers, but they fail to mature into antibody-secreting plasma cells, so the patient has low levels of multiple immunoglobulin classes, low IgG, and usually low IgA and/or IgM, a hypogammaglobulinemia. The correct answer is C. The presentation distinguishes it from other antibody deficiencies. CVID typically presents LAT in the teens to adulthood, often 20s-30s, with recurrent sinopulmonary infections. Encapsulated bacteria leads to otitis, sinusitis, pneumonia, bronchiectasis, and GI infections, e.g. Giardia. It also carries an increased risk of autoimmune disease and lymphoma. Contrast. X-linked Bruton agammaglobulinemia presents in infancy with absent B cells, BTK defect. Selective IgA deficiency has only low IgA, often asymptomatic, anaphylaxis to IgA-containing blood. Treat CV IgA containing blood. Treat CVEG with EVG. The normal B cell number, hypogammaglobulinemia, presenting in adulthood is common variable immunodeficiency. Block 35 is done. Let's review the 5 biggest traps from this block. Trap 1. Emphysema increases lung compliance by destroying elastic recoil. Flabby, easy to inflate but won't empty. Fibrosis decreases compliance, stiff lungs, and hysteresis means it takes more pressure to inflate than to deflate because of surface tension. Trap 2. Alport syndrome is a type 4 collagen defect, usually X-linked, hitting the basement membranes of kidney, ear, and eye, hematuria, sensorineural deafness, and ocular problems. Can't see, can't pee, can't hear a bee. Trap 3. Small cell lung cancer makes ectopic ADH and ACTH and causes Lambert-Eaton. Squamous cell makes PTH per P and causes hypercalcemia. The S's go together. Don't swap them. Trap 4. Acute tubular necrosis is intrinsic injury, muddy brown granular casts, and a FeNA above 2% from ischemia or nephrotoxins. Renal azotemia has a FeNA under 1% because the tubules are intact and avidly reabsorbing sodium. Trap 5. Hypokalemia predisposes to digoxin toxicity because potassium and digoxin compete at the same pump, so diuretics are a classic trigger. Look for yellow-green vision and arrhythmias and reverse with digoxin-specific antibody fragments. 35 blocks, 700 questions, train process, not memorization. StepLogic, learn how to think, not memorize.